Good morning, and thank you for SAGES and the chairs to invite me to give a talk on enhanced recovery for foregut surgery. And I'm really glad that Bruce pointed out that enhanced recovery is more of a philosophy and a concept rather than sticking to strict guidelines. Though guidelines do help us go in the right direction and achieve our goals, and we're able to measure whether we have achieved the goals or not. So foregut surgery, we all know that esophagogastric resections are complex procedures. They traditionally were associated with very high mortality, almost to the range of 50% back in 1960s. The first person to report mortality for esophagectomy less than 10% was a mere 25, 30 years ago, Dr. Uringer. Since then, in high volume centers, the esophagectomy mortality is about 0 to 1, maybe 2%. And that is why it has allowed us to talk about other things such as getting the patients out of the hospital faster and decreasing the morbidity. However, the high morbidity still persists. Even in high volume centers, it is 20 to 30% patients after an esophagectomy get some complications, and all complications are associated with even longer ICU and hospital stay than the routine esophagectomy, in which 2 to 3 days of ICU stay and 10 to 12 days of an hospital stay is still not unusual to see except in some high volume centers. The concept of IRAs, as mentioned, was introduced and pioneered and pretty much kind of streamlined for colorectal surgery, and if you look beyond it, it is very little data out there. However, it is essentially a series of interventions or pathways or written guidelines that allow for a patient to be discharged early and have a speedy recovery than what was happening before these interventions were taken. In my opinion, it's essentially charting out together that how the postoperative course would be and plan for the discharge and beyond, even before the surgery is undertaken. What steps can we take so the patient can go home in a safe and the earliest fashion? IRAS, a formal IRAS program, includes written protocols, and it usually includes one or more of these components, from preoperative teaching to how to avoid damage, more damage or more tissue stress during surgery, improve patient pain relief, improve mobilization, and early nutrition. These are the components can be divided. It can be in the preoperative setting, the intraoperative setting, or in the postoperative setting, but it's also important that we always go back and see that which parts were we lacking. We audit ourselves and how our interventions are improving our outcomes. I think we're a little far away from that for most non-colorectal cases just yet. I think in the preoperative setting, looking at the pre-admission counseling is very important. Traditionally, we have restricted ourselves to talking to the patient about the risks and benefits of the surgery. If you don't do this, this is going to happen. These are the complications, and each patient is spent a different amount of time depending on their anxiety, how much we explain to them, and so forth. However, I came across this manual from Montreal in which they went a step forward. It's a 44-page booklet that is given to the patient before major esophageal surgery, such as an esophagectomy. If you look on the right side, it introduces what the surgery is, what to expect. It tells the patient what to do before the surgery, how to prepare for it, where to come on the day of the surgery, where the family will wait, how long can they expect to be in the operating room, what will happen on day 1, day 2, day 3, day 4, and as things are going forward, they'll be discharged on day 6 or 7, and then what to expect when they go home. It's an amazing manual. It's like example, our patients come into the hospital, and post-operatively, they're in kind of a stupor, and we tell them, have you done your incentives parameter? Most of them, half of them are either trying to blow the air out rather than sucking it in because we have never taken the time to teach them how to use the incentives parameter. So simple measures of teaching the patient how to do the incentives parameter before the surgery, when they're awake and alert, would do a lot more, that they will be compliant and follow the instructions properly after the surgery when they're half in a stupor, half dazed, more scared, and in pain. So I think all these things make a huge difference what to expect, rather than the patient's question, when's my tube going to come out? When am I going to be able to get the catheter out? If they know up front, they probably will be better forewarned and hence better forearmed. So it'll help. The other parts of, besides the counseling would be, I think it's been shown that our traditional concept of doing a bowel prep for a lot of cases, thankfully, we have stopped doing any kind of bowel prep for even for esophagectomies, which I used to do till about 5, 6 years ago. Prolonged fasting, which my anesthesiologists yet have not agreed to let go of, but both these things leave a patient in a fair dehydrated state. It has been shown that if you can do complex carbohydrate load and liquids up to 2 hours before the surgery, so no long prolonged fasting, we can imagine that how many cases we have had to cancel or delay because the patient is not NPO for more than 8 hours. But there are physiological advantages to having a complex carbohydrate load just till 2 hours before surgery. There is increased and improved insulin sensitivities. There is less sugar fluctuations, and the patients do overall better. Do not forget the basic concepts. Antibiotic prophylaxis, not just as something that has to be given, but has to be timed correctly. Same with DVD prophylaxis. It's no point to give DVD prophylaxis after the patient has been induced on the table positioned after the pneumoperitoneum is obtained. It needs to be given 30 minutes before induction. These things have to be paid attention to and discussed in our team that it happens. What can we do intraoperatively? Again, at all these points, we are talking how will the patient get out of the hospital faster? Use short-acting anesthetic agents rather than doing long paralytics. Maybe Nimbex is a better idea. I think a mid-thoracic epidural for esophagogastric resections, not a lower lumbar, not a lower thoracic epidural, which will give you analgesia below the belly button, but a mid-thoracic epidural, which is technically more difficult, and a lot of anesthesiologists don't want to put it in. But it is the best way to give analgesia to the patient. It decreases the requirement of anesthetic agents during surgery, decreases use of narcotics during the surgery. The patient's likely to wake up faster after the surgery. We can plan for an early extubation after the surgery. Second, we try to cut down the surgical time rather than the old paradigm, big surgeons make big incisions. Can we get it done with a smaller incision, even if it is an open procedure? Would laparoscopic surgery help decrease the tissue trauma? Now, I say a good surgery open is better than a bad surgery done laparoscopically, and most of you would agree to that. So it would just depend on each individual skills. I wouldn't lay my sword on that a laparoscopic surgery is better than open surgery in all cases. I think most important thing is to do the surgery correctly with decreased complications. Very important to maintain normothermia during the surgery. The body warmer, the fluid warmer, so the patient is more normothermic after the surgery. Avoid excessively overloading the fluids with fluids, goal-directed resuscitation. And this is what we talk about, the fluid therapy. Traditionally is the line that has the wide swings. A patient comes in dehydrated, they've either had a bowel prep or they have been NPO for 6 to 8 hours. Then during the operating room, they get some more tissue trauma, they lose third space volume. We back up with a lot of fluids and we continue. There is a vicious cycle of tissue edema and more fluid requirements. And it has been shown in esophageal surgery that a more than 2.5 kilo weight gain, which is about 5% of the body weight for an average person, is associated with worse outcomes, not only for pneumonia and fluid overload, but mainly even for anastomotic complications. So it becomes important that we have less degree of fluid shifts. Don't bring them in dehydrated. Don't give large amounts of volume. And I think some of my old residents here would be laughing because till 5-6 years ago, I used to give a lot more fluids than I do right now. So we all change over time. Then this is the postoperative period in the hospital, which we pay a lot of attention to. We all know that, continue the pain control with epidurals. In colorectal surgery, they've avoided NG tubes, but I would say in esophageal surgery, we are not yet there. Prevention of nausea, make sure if the patient is not feeling well, he's not going to be able to cooperate in the care postoperatively. Again, avoid flooding the patients in. Try to remove the drains and catheters as early as possible. It does get into a problem whether a patient with a mid-thoracic epidural can void if the epidural is continued or not. Early enteral nutrition if possible, and you can only achieve that with a feeding tube if they don't have an ileus. So how to decrease the chance of ileus is less tissue trauma, less fluid in the surgery, and use of non-opioid analgesia. Try to use multimodal ways of taking care of pain control so the patient can be ambulate better, the gut can be simulated if need be, and postoperative care. So during the postoperative measures, it's one thing the patient did not have before they came for elective surgery is pain. So it is our responsibility to take care of their pain, and rather than using the traditional long-acting narcotics, maybe we can use multimodal local agents such as thoracic epidural. We can use NSAIDs that have a different side effect profile, So IV lidocaine has been described and or continuous local effusion. But the concept is try and use small amount of multiple drugs to decrease the side effects of one individual one, but get the cumulative benefit to get good pain control. Control postoperative nausea and discomfort. And like I said, when a patient comes out of surgery, this quite uncommon, not uncommonly, they're in a case, a slight degree of confusion and some delirium maybe even. We can avoid this by not giving benzodiazepines preoperatively and avoiding them postoperatively, making sure they get adequate rest. Do we need to wake our patient at 4 o'clock or 5 o'clock every morning for a blood draw and an x-ray? Can we delay that till 8 o'clock? The only person who benefits by doing the 5 o'clock, 4 o'clock lab or an x-ray is that when I'm rounding at 7:30, I would have the lab results. But if I've set written protocols that as long as a patient's looking fine, which I look at 7:30 in the morning, and the labs are okay, when they come back at 9 o'clock, the person on the team can advance the care to the less level. So all those things can be instituted with written protocols, which would be part of IRAs. Something specific to esophageal surgery, we do look at anastomosis. Traditionally, it's usually 7-10 days. We try to do it earlier, now 5 to 6 days, either with a transnasal scope or a swallow study. Japanese paper has said you can assess the integrity for anastomosis on day 1 and know whether the patient's going to have a leak or not. Try to remove the drains early, get the patient out and up about. So, but all these components, you may say that I'm doing great, would not be good unless we can audit them. So we need to have data before we get started. We implement them and then see how the outcomes are, which parts are working, which parts are not, and how to keep changing them. And for this, it requires a lot of teamwork and a lot of dedicated resources for which usually the hospital has to make a contribution to. So what are the results of the early enhanced recovery? Again, it's a philosophy. Maybe this word was not used by everybody in the studies that I'm going to quote, but the philosophy was same, how to make a protocolized improvement of the patient's hospital course and get them out of the hospital faster. There are just about 6 or 7 surgeries that have retrospective and prospective controls, a total of about maybe 700-800 patients all over the world. Majority of them are from outside the United States, and maybe that's why I was asked to speak. I was the only local guy, but I was not part of any of these papers yet. So if you look at that, it's not been very consistently applied. There are no randomized prospective trials, at least for esophageal surgery, esophagectomies. But the general theme is good pain control, as majority of the studies have epidural emplacement, start of early nutrition, move the patient faster, and I think very important, have pre-established discharge criteria. And this is when we're trying to achieve in so many more days. So what were the conclusions of all these 7? Rather than bore you through individual ones, was a fast-track esophageal resection is safe as traditional approach, meaning the patient will not go home and have a complication at home with a leak and come back. That is our first fear. I don't know, what if they have a leak at day 10? That does not happen if the patient is doing well at day 7 and gets discharged. It does significantly reduce patient morbidity, but most importantly, the length of stay in the hospital. Hospitals, contrary to my earlier belief, are not the best place for the hospitals, for the patients. And there are significant clinical and financial implications. The hospitals will do better under these DRG paid systems. However, all these studies also caution that there is an increased rate of failure of adherence of these preset protocols, especially if a patient has a complication. Obviously, we can imagine, you can't be sending a patient home if he has an anastomotic leak. And also if the patient was elderly and or if they had received neoadjuvant therapy. One of the papers reported that patients who did not have neoadjuvant therapy before an esophagectomy, less than 5% fell off the IRAS pathway, and almost 30% fell off the IRAS pathway if they had neoadjuvant therapy. So we can conclude that IRAS can succeed only if there are no post-op complications. And how do we get to that factor? We can decrease the risk of complications by assessing the neoadjuvant therapy, the frailty index, and the hospital surgical volume. I will be done in 5 minutes, I promise. The neoadjuvant therapy, we have taken that neoadjuvant therapy is a standard for locoregional advanced esophagogastric cancer. There is definitely, some papers have said there is no change in post-op morbidity. A lot of other papers have said there is an increased post-op morbidity, increased complications. Definitely no one has said that neoadjuvant decreases the post-op complications. So at best, they might be same. So we should be careful about how much and should everyone get neoadjuvant therapy or not. And if we are giving neoadjuvant therapy, should we give both chemoradiation therapy, or should chemotherapy be alone sufficient? And there are increased complications during a bimodality neoadjuvant therapy, so the patient is much weaker, and there are more postoperative complications if we had radiation therapy in addition to the chemotherapy. And there have been two studies. This is actually 800 patients out of England, the biggest 400 patients in each arm followed for more than 10 years, that there is an improvement of survival just with neoadjuvant chemotherapy is to the same degree as reported in other series that give both chemo and radiation therapy. For surprisingly, I never have this paper being discussed anywhere at any conference of giving just preoperative chemotherapy. The point being, should we need to give neoadjuvant radiation therapy or not? Recently, a paper published just an analysis of all the results of the national database that there was no survival difference in patients with esophageal cancer, whether they had preoperative chemotherapy alone or preoperative chemo and radiation therapy. The surprising part, in the United States, only 10% of people out of 7,000 patients had only chemotherapy. 6,300 patients, was 90% of the patients potentially had an unnecessarily additional treatment that potentially increase their complications. And those patients will have a lesser time adhering to the IRAs. What about the frailty? We know that, like mentioned, all patients are not equal. Are certain patients at higher risk? It would help us predict post-op complications, the length of stay, mortality, and we won't beat ourselves up if a 85-year-old man doesn't go home in 6 days after an esophagectomy. This is a paper on esophagectomy, just looking at the frailty index. They calculate a modified frailty score, and if as your score goes up, your mortality, which is in the green line, and morbidity, which is in a red line, clearly increases. You can see that the patients who are on the right side of the graph cannot be expected to go home in about 6 to 7 days. The question comes is that can we identify them before the surgery using these scores? 2, can we do something to prevent these complications or improve their frailty? 3, can we prepare them better by counseling? And most importantly, should we even be operating on these people if we cannot improve these scores? Is it okay to justify 1 out of 5 mortality in a patient for an elective surgery? Is it okay to justify a 65–70% morbidity for an elective procedure in somebody who's very frail? And if we find that these patients don't have a survival benefit, should we even be operating on these patients? Other questions that go beyond ERAS, but I thought I should raise them up. This is a pet topic of mine, is surgical volume. I think both the hospital and surgeon volume matter. It has been shown most for esophageal surgery. I'm not going to talk about pancreatic surgery and other surgeries. It has been shown in. Clearly, if you do something more commonly, you're going to do it a little better. England made a concentrated enough in the British healthcare system to centralize esophagogastric surgery. They did an audit 15 years later. Their mortality declined by 66%, from more than 10% to down to less than 4%. And their overall survival improved. So they concluded that it was a very good idea that they centralized their care. And it has been shown in the US 10, 15 years ago that depending on the number of cases done in the hospital facility, a high volume center versus low volume centers, the mortality difference is 4-fold difference, from 25 to 30% mortality in low volume centers down to 5% or less, and even much lower now in high volume centers. And what is that? 20 cases a year. So 2 esophagectomies a month in a hospital correlates with improved survival for the patient. However, recently it was assessed that the median number of esophagectomies done in the US hospital were 2. Roughly 6,000 operations done in 700 different hospitals. Median number of cases per hospital, 2. Only 23, 1 out of 4 patients, or 1 out of 5 if you look at it a little pessimistically, had their surgery done at a high volume center. Are we doing right for our patients? Can we even implement ERAS guidelines in a setting where the risk of complications, morbidity, and mortality is so high and so few patients will be a part of it? I think in end, ERAS and esophagectomy, it is feasible. It is implementable. I think if we have written guidelines, we can do it. It does improve the perioperative morbidity and definitely decrease the hospital stay, but we need to identify patients who are at high risk of failure, whether they are frail, elderly, and or neoadjuvant treatment has been given. But I think the biggest change we'll make is by centralizing to high volume centers, because that will be associated with a significant decline in morbidity and mortality. And then only we can also justify the cost of involving the whole system to create protocols for a larger number of patients who are undergoing an esophagogastric resection. Thank you. Thanks a lot.